So guys, let me know if you can see my screen, please. Okay, you can see my screen, right?
Yes.
Yes.
Okay, thank you. So the next topic we're going to be talking about is taking a history. Okay. Mm, well, we just call it a history. We call it history by what we all know by the name of Historia Clínica, right, in Spanish. Okay, give me 1 second. We just joined. Okay. Welcome, guys, to all those who just joined our session. Okay, so what is actually history? Um, we actually in English know this term as a medical history, okay? In Spanish would be historia clínica, right? In English, medical history. So basically what we're going to do, we're going to be talking about today is how and well, first of all, the main points and the parts of medical history and what details you have to focus on to have a good history when you well in your general practice, right? So what is medical history? It is actually, sorry, okay, first of all you have to you always have to take into account that it is actually a legal document. Okay, so this legal document um, is like a report, right? That includes some information that you're going to gain from two main sources. Okay, so the first one is relevant recollection and questioning. So you do have to investigate a little by asking your patient, and if your patient, for example, just passed out, fainted, right? You have to get this kind of information from the family members of your patient. Okay. And of course, you're going to get also information from the physical examination. As some physicians should like generally take their time to take history, some situations, just like medical emergencies, may only provide just a little information or enough information to shorten times, right? I mean, you're not going to talk about uh, social economics history in your patient who is bleeding out, right? So in some cases, just like medical emergencies, you only have to get some the main points to shorten time and to avoid delaying from potentially vital interventions, right? For example, you have your patient who is in a septic shock, or maybe needs surgery. So you're going to focus on the important things. However, there are some other times in which you have to focus and investigate a lot more to get to your final diagnosis. Tomorrow we're going to talk a little bit about the different types of diagnosis, because you know there is a clinical diagnosis, anatomical, symptomatic, and a lot of diagnosis types of diagnosis actually. So for you to understand and to point the right direction to get your precise, more accurate um, diagnosis and therefore treatment, you have to investigate a little bit in some occasions. And in some other, you just have to focus on the main ones. And there is like an uninterrupted setting in a quiet room. You do it this in a quiet room with only the examiner, which is you, right? And the patient, and you both have to make sure that the patient can openly discuss the concerns and the reinforces the patient and physician relationship, right? We call this in Spanish la relación médico-paciente, right? So depending on the patient's concern, some other additionals and some other and additional information you could get. In fact, if this additional information is appropriate for you to get to a good diagnosis. Okay, so what are the parts of the main parts of a medical history? Okay, you have it on your screens. The chief concern, right? Which in Spanish, well, I'm going to say it in Spanish for you to understand this, all of these terms, for you to understand the whole thing. Okay, so chief concern is actually what in Spanish we would call motivo de consulta, right? So the next one would be history of present illness. In Spanish is just like that, la historia de la enfermedad actual, right? Past medical history. Well, here you are questioning your patient about some diseases that might have gotten from the childhood to your patient's age, right? Throughout his or her life. Family history would be antecedentes familiares, right? Social history would be related to some, well, to some things that your patient is used to doing, some habits, right? Also related to how your patient lives, and if your patient has some different types of the acquaintances, okay, of your patients in a social point of view. And the last one would be the review of systems, and right after we would have the physical examination. So we're going to talk about each one of these today. So chief concern, what is it? It is actually the main reason for the patient's visit, okay? What is the goal, the main objective here? Is to record the chief concern or main concern clearly in the patient's own words. For example, you know, e.g. means example gratia, right? It's like, por ejemplo, right, in Spanish. So your patient is telling you that his or her knee hurts, right? Has an upset stomach, runny nose. Does anybody know what runny nose is?
It's, can I say in Spanish?
Yes, great.
Es como que una persona tiene mucha mucosidad que está sacando cada rato, constantemente, por decirlo de una forma.
Yeah, great. That would be it. Okay. Thank you. Okay, so that's what you're going to get from your patients. That kind of vocabulary, because you know that our patients are not always used to medical terms. Okay, so when we're taking actually a patient's medical history, the first question that we should be opening our intervention in order to enable the patient to freely describe their concerns would be something like this. How may I help you? What brings you here today? Right? So some sentences that you might find useful to enable your patient or to make your patient more comfortable, because you're going to, or you have to get some information from questioning your patient. So this would be a good way to start. Okay, so the next one would be history of present illness. What is it? It is actually a detailed description of the chief concern and progression of the symptoms. And it has several goals actually. The first one would be to provide comprehensive details of the patient's present illness from the initial symptoms or from the previous encounter, and to determine which system should be assessed carefully in the review systems and physical examination. Okay, so basically what we're going to describe here is the chief concern in a more detailed manner, right? So our patient is, for example, here we just give an example that if your patient tells us that his or her knee hurts, we're going to start detailing that information. The onset, for example, onset means inicio, right? When it started, describe the type of pain, how, well, if your patient is taking any medication on his or her own, not non-prescribed medications and all that kind of stuff, okay? So that this is what we're basically going to focus on, history of present illness. So as I was telling you, we're going to focus on some key points. Okay, what are those key points? The onset of symptoms, right? And that onset means inicio, okay? Onset of symptoms, the context and the location of any symptoms that your patient might have. The second would be the quality and intensity of symptoms. For example, when we're trying to grade our patient's symptom, which, for example, would be pain, right? So we're going to ask our patient to tell us in a scale from 1 to 10, with 1 indicating a low amount and 10 the maximal intensity of symptoms. So we're going to basically tell our patient to tell us well, we're going to ask our patient to tell us how intense the pain is. Okay. The next one would be the course. For example, it was a sudden course, like abrupt, right? Sudden means abrupto, that started right, uh, like a few hours before the consultation. That would be sudden, right? Or it might be gradual, like it started like I don't know, like 2 months ago, and the pain just worsened through the time. Okay. Another example would be how constant it is. If the pain is present all the time, if it is present only at nights, if it's present in the mornings. Okay. Or well, well, those would be examples. Okay. The next one would be duration of symptoms. If it hurts all the time, for example, okay? If there are associated symptoms, if there are factors that improve or exacerbate symptoms, and if it triggers or the patient's own explanation of cause of the symptoms, okay? So we have to focus on these key points to describe history of present illness. You get it, right? It's really easy. So we have to focus on these key points to have a good record of our patient's history of present illness. So there are actually two types of history of present illness. There are two types of how you can describe your patient's symptoms. There's a brief means breve, right? A brief HPI. HPI stands for history of present illness, right? It actually includes from 1 to 3 elements. For example, a dull pain, right, in the left knee over the past 2 weeks. Okay, so we're having like the basic information here, and maybe the most important information. However, mm, the more information you get from your patient, the better is going to be your medical history when you start recording your medical history. You will have a more accurate intervention and accurate diagnosis, and therefore you will have a more precise and accurate treatment. So this is for all of you guys, the extended HPI. It is actually includes over 4 elements. And here we have a more detailed information. Taking the same example as we just talked about, we might be saying that, well, our patient has a dull pain in the left knee over the past 2 weeks. And the patient stated that the pain started after his or her fall during a soccer game, for example, and the pain relieved by sitting, warm compress, ibuprofen, and aggravated by walking or standing. So here we have more detailed information about how your patient is going to describe. Of course, your patient is not always going to tell you everything just as detailed as in this example. You have to get information. You have to ask, okay, what kind of, how could you describe your pain? How intense it is? And do you find relief by doing something? Do you find relief after taking any kind of medication? Does any situation worsen the pain? Okay, you have to investigate. Your patient is not going to tell you everything you need to know. You always have to get more and more information. So, you know, the most common chief concern in medical practice is, do you know what the main reason for a patient consultation is? It is really easy. Most pains actually go to consultation due to pain. So pain is actually the most common reason for your patient to go to your consultation. And at least here in Bolivia, well, patients tend to get some medications uh, on their own. They do not need a prescription from a doctor, right? So they get medications just like as if they were candies, right? They actually trust more on their family members, on their friends. rather than a doctor, right? So you're going to get patients after taking a lot of medications. They're going to tell you, well, I had this kind of pain, so I bought this, I took it, I didn't feel better. And then I took that or other medication, I didn't get better. And well, that's why I'm here. It's like you're the last resource, right? So this is actually um, common here in Bolivia. It's a shame, but that's how it is. So another key point for a history of present illness, and as I was telling you that pain is actually the main reason for your patient to go to your consultation, you have to know how to describe pain. Okay, in Spanish, you'll can anybody tell me of these famous mnemonic to describe pain?
Isn't it Alicia?
Great. Could you tell me in Spanish what each letter stands for?
Um, the A is for the aparición,
Okay.
L location of the pain,
Okay.
Ali,
Do it in Spanish.
ok. A es de aparición, L de donde se encuentra, eh, el, perdón, la I es de la intensidad, la C es de características del dolor, la I es, no me acuerdo qué era la I,
Radiación, right?
irradiación, y el último es agravantes o lo que baja el dolor.
Atenuantes, right. Okay. Yeah, great. So that is actually a mnemonic that I always tend to use because it helps us a lot to describe pain, right? When I'm writing down a medical history, I always, if the patient tells me that feels pain, I always ask my patient to describe all these types of characteristics to get a better diagnosis, right? And you should also, because it's really, really helpful. Okay, so that is in Spanish. And since we're in an English class, right, we have to get another mnemonic, which is liquor AAA. Okay, so the L stands for location, right? Just like in Spanish. Intensity, right? Well, the I stands for intensity, and we actually have a scale, right, to degree how painful it actually is for our patient, right? Actually, you have to note that pain, which is the most common reason for your patient to go to your consultation, right? Pain is just cannot be actually measured objectively, right? And a patient's perception of discomfort may not always be consistent with the severity of any condition that your patient might have. So it is actually what your patient feels, right? You know that actually men have a lower mm, pain tolerance, and actually women have higher pain tolerance. They can deal better with pain, actually. So it is actually very subjective, right? Depending on your patient and how your patient deals with pain. For a patient, maybe like, for example, a really, really bad pain would be in pancreatitis, right? For some patients, and I really got to see this kind of patients, this patient already had the diagnosis of pancreatitis. However, this patient just told us that the patient, we asked him to tell us how bad it was. I mean, the pain, right? And he told us like three, four. That would be it. And he was real calm. He had a normal heart rate, which would mean he didn't actually feel that much pain, right? Because you know that when there is actually pain, our heart rate increases, right? And we would actually reach a tachycardia. So this patient had a regular rhythm and actually had a normal heart rate, which actually did tell us that he wasn't in that much pain, right? So it depends on your patient's characteristics. The next one would be the Q, which stands for quality. For example, it is a sharp type of pain, it is a burning type of pain, it is a pressure-like pain, right? For example, did you know that in acute myocardial infarction, the patient actually does not describe this discomfort as pain. He describes it as if something was on his or her chest and it's like pushing, right? So this would be a pressure like pain, okay? DO well, it is actually stands for the onset. In Spanish would be inicio, right? And not only is the entire period of pain relevant here, but also whether the pain is permanent or if there are pain-free intervals. Okay, it's like we're trying to investigate if this pain that we're trying actually to describe is present all the time or if the patient does not feel pain all the time. Okay, the next one would be the R, which stands for radiation. Um, uh, well, there's a like a typical example is like the radiating pain in myocardial infarction, as the example I was telling you about, right? Which is often to the left arm, but also could be to the jaw and the upper abdomen. Okay. Do you know, does anybody know? Well, I'm going to ask you in Spanish, and I hope someone knows this, okay? Eh, ya sabemos que en el infarto agudo de miocardio, la típica irradiación es por el borde cubital del miembro superior izquierdo, se puede irradiar a hombro, a dorso, se puede irradiar hacia epigastrio, pero ¿alguien sabe a qué zona no se irradia del lado izquierdo? Which actually would be a finding, a clinical finding that would help us differentiate between a myocardial infarction from the inflammation of one layer of the heart. That would be the clue. Does anybody know? Okay, I'm going to say it in Spanish, okay, guys? Bueno, por lo que leí alguna vez, decía así que en el infarto agudo de miocardio, el dolor se irradia, bueno, tiene la irradiación típica, ¿no es cierto? Hacia el miembro superior izquierdo, por el borde cubital, al dorso, a hombro izquierdo, a epigastrio, pero según lo que leí, de hecho no he visto ningún paciente, pero lo que leí es que no se irradia hacia la zona del trapecio. Y cuando se irradia a la zona del trapecio, podemos más pensar en otra patología. ¿Alguien sabe cuál? Okay, that's homework for you guys, okay? So the next one would be the aggravating factors. For example, some fatty foods, like greasy foods, right, usually aggravate the pain in the biliary colic, right? The gallbladder when it is inflamed and well, our patient just ate, I don't know, any greasy food due to the a hormonal stimulation would cause the gallbladder to go stiffer, right? And that would be hurtful. That would be an example. Now, does anybody know what kind of hormone we're talking about here related to the pain in cholecystitis after eating greasy foods or fatty foods? Come on, guys. It is a hormone that is produced in the small intestine. Come on, guys. Okay, it is cholecystokinina. Okay. And the next one, the next A would be alleviating factors. For example, fasting. Does anybody know what fasting is? Fasting.
I think it's when you don't eat food for a period of time.
Yes, in Spanish would be. Hello. Hello.
You know?
Yes, great. Actually, there's a type of diet, right? To um, decrease body weight, right? Which is intermittent fasting, right? Which would be ayuno intermitente, right? So, for example, fasting usually alleviates the pain in the biliary colic, right? However, did you know that when you tend to this fasting, you actually are more able to have more calculi. It is actually, well, there's an explanation in which, well, if you do not eat anything, the gallbladder is going to stay still, right? It's not going to send, it's not going to send its content to um, start absorbing the nutrients, right? And since you're not eating, the cholesterol inside the gallbladder is going to sediment and form calculi, okay? And the next A would be associated symptoms. For example, a patient with an intestinal obstruction would likely present vomiting, right? Constipation and peritonitis in addition to abdominal pain. So there are a lot of um, symptoms that might be associated with determined disease. So it would be really useful for you to memorize this mnemonic, just like you do in Spanish with Alicia, right? So the next one would be the past medical history. So what is it all about? This is actually a patient's health status prior to the current visit. So any information previous to the current visit to your consultation is going to be relevant. Okay, what are the main goals here? To identify important clues and contributing factors regarding the current concern, and to develop a holistic approach to patient care. So, as we were doing with all the previous ones, we're going to talk about the key elements. For example, childhood illnesses. Uh, this is an example I always tend to use about asthma because asthma has an epidemiological curve which has two pikes. The first one is between no, it was from 5 to 7 years, and the next peak would be around the 40 years, okay? So if your patient goes to your consultation with an asthmatic crisis, you have to ask if your patient when he was from 5 to 7 years old had this kind of symptoms as well. So that would help us to differentiate between asthma and in Spanish would be EPOC, right? Oh, or in English, OPCD, right? And the next one would be major adult illnesses. For example, it may be helpful to go through the organ systems with the patient. For example, do you have any cardiovascular, gastrointestinal tract, or lung conditions? And the most common diseases, possibly avoiding some technical terms like COPD or coronary artery disease or hyperthyroidism, right? You have to ask if your patient has any gastrointestinal, a lung condition, a cardiovascular condition, rather than use some technical terms as I was telling you, COPD, for example. And you have to try to maintain a chronological order in documentation and note pertinent information at the time of the diagnosis. This is actually really, really important because this is going to help you a lot to get a better diagnosis. The next one would be the past surgical history, including the type, date, and localization of some previous surgical procedures. This is actually important because it may influence the surgical approach. For example, preceding abdominal operations predispose to adhesions, which help, it's like, will make laparoscopic procedures more difficult. In Spanish, you're going to understand this better. For example, cuando tienen, los pacientes tienen cirugías abdominales previas, tienden a hacer bridas y adherencias, como es como se lo conocen, ¿no es cierto? Entonces, tenemos que saber que el paciente ha tenido varios procedimientos quirúrgicos abdominales para saber que el procedimiento laparoscópico, por ejemplo, que tenga por una nueva operación, una nueva cirugía que esté programada, va a ser más dificultosa porque van a haber más bridas y adherencias que van a dificultar el manejo del instrumental quirúrgico, right? So this is what this is important for. And medications, actually, medications, when you have to document the medication that your patient is taking, the name of the active agent should be noted. In addition to those, frequency of intake and administration form. Okay, you have to write down the main active form of the medication, how frequent your patient takes this medication, and the administration form. For example, aspirin, right? Aspirin 100 milligrams, one time a day, for example. And there's actually a way of telling your, actually a way of writing down this information. For example, 1,000 PO. So the numbers indicate the dose, right? 100 would be 100 milligrams, right? And the time of the day this medication is taken. And PO, for example, actually in Spanish, we could use PO. Does anybody know what PO means?
In Spanish, if I'm not wrong, it's postoperatorio.
No, this we're talking about the administration form of a medication. How do you say your patient is taking any medication orally by his or her mouth in Spanish? Via oral, right? So we use VO, right? However, it would also be correct in Spanish to use PO. Does anybody know what PO means? Okay, it actually means per os, which is actually in Greek, and per os means por la boca. Okay, so we would actually consider right, we would actually consider correct to tell per os or PO any medication that our patient is taking orally. Okay, it is actually also correct VO, via oral, right? In English, we actually use the Greek version, which is PO. So in this example, we would have aspirin 100 milligrams, like aspirin 100 mg, right? Milligrams, and PO, which means per os, through the mouth, right? And women should be asked whether they take a contraceptive pill, as patients may forget that it is a medication, and they may not always take that into account. Okay, so we have to talk about some prescription drugs, the over-the-counter drugs, herbal remedies. Here in Bolivia, we have a lot of this kind of stuff. Doses and frequencies. So we have to write down all the useful information of how your patient takes his or her medication. Okay, so the next one would be allergies. Some drugs or environmental factors, for example, some drug allergies and allergies to iodine used for sterilization, latex contained in gloves, for example, and some other materials the patient may come into contact with during or after a procedure. For example, are allergies to metals, for example, any kind of implant that your patient might need, right? Some reactions to each allergen. Actually, here, for example, an antigen that elicits an IgE mediated type or type 1 hypersensitivity response in some individuals with an allergy to a substance containing the particular antigen, and some food intolerance. Here, actually, we have to make a distinction between the allergies and intolerance. For example, against food or medication, it may be a clinically relevant information. And intolerance usually manifests with gastrointestinal symptoms. For example, nausea and abdominal pain right after the ingestion. Okay, so we're going on to the prior injuries. For example, motor vehicle accident, any type of fall, prior hospitalizations and transfusions, immunizations, screening exams, for example, pap smear, which in Spanish would be Papa Nicolau, right? Mammogram, colonoscopy, and one that I didn't write it down here would be psychiatric illnesses, which would include any psychological intervention or hospitalization. So we're going on to the family history. It is actually a history of disease in first and second degree blood relatives that reaches back at least 2 generations. So the more information we get from your patient and your, well, the relatives, your patient's relatives, right? You're going to get more information and you're going to get a better medical history. What are the main goals here? To detect hereditary patterns of disease and to identify contagious diseases and analyzing risks and providing preventive measurements. So as we were doing right before, we're going to talk about some key elements. For example, the age and health status of first degree blood relatives. We have to make a list of major medical conditions of first degree blood relatives. We have to focus on the age of onset and progression. Also, we have to take into account the genetic defects. For example, I don't know, cystic fibrosis. Does anybody know what cystic fibrosis is? Okay, homework for you guys. Some other genetic defects, for example, in beta thalassemia, hemophilia, Huntington's disease, and some other, okay? We also have to focus on the living status of first degree blood relatives. For example, if the relative, this patient's relatives are deceased, passed away, we have to note the age at death and the cause of death. If the relative is alive but ill, we have to mention their diseases and prognosis. And if the relative is alive and in good health, we have to note alive and well. Okay, and you have how you could, well, abbreviate that information, A and W, right? Alive and well. We're going on to the social history. It is actually a part of medical history that addresses social aspects. For example, occupation, socioeconomical status, drug use of the patient's life that might be pertinent to current medical condition. What are the main goals here? To get to know a new patient as a person, to acquire enough information to support accurate decision making and choosing an appropriate treatment option, promoting healthy behaviors and lifestyles. So what are actually the key elements here? Personal data. For example, the place of birth, history of childhood and adolescence, level of education, and marital status. So here we have like personal data, the age, and all that kind of information, right? And the next one would be occupation and current job. It is actually important for us to investigate this because work is like a major stress factor for many patients. And moreover, some various occupations are associated with health hazards. For example, exposure to heavy metals or carcinogenic materials. Okay. Okay, so we have to focus on the socioeconomic status and living situation, the safety and health counseling on lifestyle hazards, social support. It is also important because for example, does the patient live alone or do they have the support of children or a wife or husband? In any case, for example, a spouse, right? A partner. This is actually really important and it may not be, it may not seem like it, right? For example, we have this patient that is 80 years old, lives alone, and has a pneumonia. We actually have this scale, which is called CURB 65. Can anybody tell me about it? CURB 65. Does anybody know what these letters stand for and number? Come on, guys. I know that you must have read about this. Okay, this I'm going to say it in Spanish, okay? La escala de CURB 65 nos permite valorar, o sea, un paciente que tiene ya neumonía establecida. Nosotros usamos la escala del CURB 65 para determinar si el paciente va a ser un paciente ambulatorio, es decir, se va a llevar su medicación a la casa para continuar el tratamiento antibiótico. Si este paciente, después de hacer la escala CURB 65, es candidato para internación en una sala común, o si este paciente, después de hacer el CURB 65, necesita terapia intensiva. ¿Ok? Entonces, por ejemplo, como les decía, paciente de 80 años con ya diagnóstico establecido por, bueno, de neumonía, no tiene una neumonía grave, entonces digamos que no requiere internación, pero el paciente vive solo, digamos que por la edad tiene una demencia senil, no está muy bien orientado en tiempo, espacio y persona por la misma enfermedad, por la neumonía, porque los altera a los pacientes de la tercera edad, los altera su percepción temporoespacial, ¿ok? Entonces, el paciente se va a acordar de que tiene que tomar el antibiótico a tal hora. No, ¿no es cierto? Entonces, de esto nos está hablando este punto. El paciente no va a poder realizar su tratamiento de manera adecuada, entonces, a pesar de que tiene criterio para que sea paciente ambulatorio, lo vamos a tener que internar para asegurarnos que recibe el tratamiento. ¿Está bien? Y para mañana me van a decir de qué se trata la escala CURB 65. ¿Ok? Okay, so we're going on. The diet also, because we have to focus on what types of food our patient eats, right? Mainly. For example, a patient who has some risk for developing type 2 diabetes actually tend to eat a lot of carbs, right? So the next one would be exercise and sports, sleep, stressors, some interests and hobbies, including recent travels and recreational activities. Recent travel information is actually really important for infectious diseases, actually. And actually, now I'm working at this hospital right here, and we actually get this kind of information. When was your last travel? Did you travel to any different city from this in the last 21 days? Where? How many days did you stay there? Were you were you with any other person? Were you alone? So this simple questions might help you a lot, because well, let's imagine you're with this pandemics, right? If your patient travels, it's not the same if your patient just traveled alone or traveled with his wife, for example. If you have your patient who has tested positive for COVID and you did not ask your patient if he traveled alone, you're missing one diagnosis here, one diagnosis, which is his wife's diagnosis, right? So this is actually important. and it may not seem like it, right? And it is actually really important for religion to ask for religions and spiritual beliefs, because at least when I was a resident, we got a patient who did not accept to get a transfusion, a blood transfusion, due to the religion. They didn't allow to receive someone else's blood. So it is really, really important, because you can get sued. I mean, you could get, los pueden demandar solo por hacer lo mejor, lo que ustedes consideran que es mejor para su paciente, pero no lo consultan o no sabían que era de una creencia religiosa que les impide recibir sangre o cualquier hemoderivado, los pueden demandar a ustedes a pesar de haberlos salvado al paciente. Entonces, this is really important, okay? And this would be the last one, actually, the review of systems. So what is this about? This is just a little list of questions and arranged by organ systems to help establish the causes and signs and symptoms. So what are the main goals here? To give a systematic approach to establish the correlation of symptoms to organ systems, identifying potential and underlying concerns that the patient did not report while taking an HPI or a PMH, and establishing positive and negative organ-specific findings. So we're going to just finish with this types of example. Can anybody tell me how we can investigate? Do you know what constitutional symptoms are? Anybody? Does anybody know what constitutional symptoms are? Síndrome constitucional en español. Anybody? Hello, are you here? Come on, guys. Síndrome constitucional. Tell me in Spanish if you want to. Hello, are you here?
Yeah. Fever, weight loss, fatigue, and lymphadenopathy.
Okay, great. So those would be the main components of constitutional syndrome, right? So since we're talking about syndrome, we actually are talking about constitutional symptoms. For example, you could ask your patient about the general state of health, including energy, strength, exercise tolerance, fever, just like Paula just told us, right? Fever or chills, right? Fiebre o escalofríos, fevers or chills, okay? And night sweats. Night sweats is actually really important for us because patients with tuberculosis tend to have night sweats, and also patients with some types of cancer, mainly what type of hematological disease? Does anybody know? Oh, or group of diseases, actually. Lymphomas, right? Patients with lymphoma tend to have also night sweats, okay? Fatigue, just like Paula told us, changes in weight to lose. Actually, this is more related to how fast our patient lost weight. A rapid weight gain is often caused by edema, for example. And it occurs, for example, in heart failure or cardiac failure. And on the other hand, a rapid weight loss, which is actually considered more than 10% of the body weight in the last 6 months, could indicate, for example, a malignant disease, as I was telling you, like lymphomas, right? Or tuberculosis. Here in Bolivia, we have a lot of this. Okay, so what would be the next? Changes in appetite, trouble sleeping, okay? That would be about constitutional symptoms. What about the eye? What could be important to ask your patient? Anybody? Hello. Paola just answered. So anyone else? Okay, for example, we could ask our patient if he wears or not glasses or contacts. Contacts, just that word, right? Contacts means lentes de contacto, right? If there was any change in visual acuity, blurry or double vision, is there pain? Is there photophobia? Is there, how is the ability to see at night? How is the ocular discharge? Is there flashing lights, blind spots, yellowish discoloration of the sclera? Is there redness? Could it be glaucoma due to the increase of intraocular pressure, right? Is there cataracts? When was your last eye exam? I mean, there's a lot of information. And what about head and neck? Anybody, could you tell me anything that you might be investigating about head and neck? Because remember, we're examining our patient with questions. For example, what type of headache, right? Is there neck stiffness? What is neck stiffness? Okay, I'm going to ask you one by one. Okay, Marcela, could you tell me what neck stiffness is and what it might related to?
I'm sorry, I have no idea.
Okay, anybody, guys? Mariana, maybe?
If I'm not wrong, it's when the muscles of the neck are in pain.
Okay, they're stiff, rigidos, right? And what could it be related to? For example, a patient with fever and neck stiffness, that would be really, really easy for you to diagnose. What would it be? What would you think of?
I really don't know.
Okay. For example, in this case would be meningitis. Okay, una meningitis infecciosa se puede manifestar por fiebre y rigidez de cuello. Really, really easy. Okay. What about ear, nose, mouth, and throat? For example, about ears, is there hearing loss? Tinnitus. Does anybody remember what tinnitus is? We already talked about it.
Syndrome of the ear.
Sorry?
Syndrome of the ear.
It is like, well, the patient tells us like that hears something ringing inside his or her ear. Un sonido. El tinnitus es un tipo de sonido que solo el paciente lo percibe, como un pequeño silbido, como un, cuando el, okay, someone's writing here. Okay, yes, ringing in the ears. That is correct. Thank you, Danitza. Ringing inside the ears, right? And what could be related to? What would this be related to? Give me just, well, there's a lot of examples that you could, that could be related to tinnitus. For example, it would be in Spanish, un signo de vasoespasmo es el tinnitus. En los pacientes hipertensos les dicen que escuchan todo el tiempo un pitido, un sonido en sus oídos. Eso es tinnitus y eso es por vasoespasmo. También hay, obviamente, causas que no son del aparato cardiovascular, que están más relacionadas con el oído como tal, con el sentido del oído, ¿no? So, that would be it. Is there earache? Earache means pain in the ear, right? Is there ear discharge? Do you know what ear discharge is? Una secreción a través del oído, okay? For example, in acute, or in any kind of infection in the middle ear, we could have actually ear discharge. When we're talking about nose, are there nosebleeds, bleeding nose, right? Nosebleeds. Is there nose obstruction or discharge? Is there nose itching? Is there change in sense of smell due to COVID? Could be, right? Is there post-nasal drainage? Does anybody know what post-nasal drainage is? Okay, you're going to check it out for tomorrow because we just it's 9:20. Okay, is there fever, for example? We're talking about mouth and throat. How are the teeth? Is the dentures okay? And is there mouth sores? Is there change in sense or taste? Is there sore throat? Is there halitosis? Is there change in voice? When we're talking about cardiovascular, for example, is there chest pain, for example? Are there palpitations? Is there dyspnea? Would be shortness of breath, right? Is there peripheral edema? Does anybody know what paroxysmal nocturnal dyspnea is? In Spanish, disnea paroxística nocturna. Por si acaso, cuando estén hablando en español, todos los términos que estén relacionados con la respiración, no es disnea, es disnea, taquipnea, bradipnea, no es taquipnea, bradipnea, no, es taquipnea, bradipnea, eupnea, disnea, okay, in Spanish, piece of an advice. Okay, does anybody know what disnea paroxística nocturna is? In Spanish, you could tell me in Spanish. Okay, someone is writing down. Okay, you're right, Danitza. Do you know what paroxystic is? Anybody? Does anybody know what paroxystic is? Actually, a paroxystic is abrupt. Okay, something like just came up from nowhere. Okay, so your patient is sleeping, right? And has shortness of breath during his sleep. That is actually in English paroxysmal nocturnal dyspnea. Okay, and it is like the difficulty to breathe so hard that could awake your patient. Can anybody tell me what this would be related to? And why? Es bastante interesante. Por ejemplo, la disnea paroxística nocturna, se los digo en español para que se entienda, ¿no es cierto? Es cuando el paciente está durmiendo, les dice, el paciente a ustedes les va a decir, y esto sí lo vi, que, que el paciente está durmiendo, él le dice, ¿no? Les dice a ustedes que estaba durmiendo y que ha sentido que no podía respirar y ha sido tan fuerte esta sensación de no poder respirar que lo ha despertado. ¿Ok? Entonces, ¿qué quiere decir esto? La disnea paroxística nocturna es cuando hay falla, o sea, hay insuficiencia cardíaca, pero está más relacionado con una insuficiencia cardíaca izquierda. ¿Por qué? Porque cuando el corazón está insuficiente, es decir, cuando hay insuficiencia cardíaca, el corazón no bombea bien, ¿no es cierto? Entonces siempre queda un remanente de sangre porque no lo está bombeando bien, ¿no es cierto? Entonces aumenta la presión intracavitaria, por ejemplo, del ventrículo izquierdo. Entonces, de manera retrógrada, obviamente, aumenta también la presión intraauricular izquierda. Y también de manera retrógrada aumenta la presión dentro de las venas pulmonares que desembocan en la aurícula izquierda, ¿no es cierto? Entonces hay un incremento de la presión en el interior de las venas pulmonares y el líquido de la sangre pasa hacia el intersticio del pulmón, entonces hay dificultad para respirar. Esa es la disnea paroxística nocturna. ¿Alguien sabe cuál es la diferencia con hay un término que se llama asma cardíaca? ¿Alguien sabe qué es el asma cardíaca? In English or in Spanish? Hello. Okay. Hello. Asma cardíaca. Okay, can anybody give me an example of respiratory when we're talking about review of systems? Respiratory guys. Brisa, maybe you didn't talk so far.
Like the types, like bradypnea, hyperpnea.
Okay, it could be. Yes, that would be an example. Yes. Another like easier example would be cough, right? Is the cough dry? Like non-productive cough, right? Is it wet? Is it productive, right? The sputum color, the amount, for example, it is green sputum, it is bloody, it shows up right after waking up. So that kind of information, right? Gastrointestinal, maybe Bernardo, who just joined back.
Yes, what is the question?
Okay, could you give me an example what would you ask your patient, or what kind of information could you get from the review of systems talking about the gastrointestinal system?
Maybe how many times go to the bathroom in one day?
Yeah, great. Yeah, awesome. Some other example, is there nausea? Is there vomiting? Is there hematemesis, right? Like bloody vomiting, right? Is there change in appetite? Is there abdominal pain? Is there abdominal distension? Is there early satiety, right? Saciedad precoz, in heart failure also. Is there changes in bowel movement? Which could be related to diarrhea, constipation, change in the stool appearance. Can anybody tell me about Bristol scale? Do you know what Bristol scale is? La escala de Bristol. ¿Alguien?
Es la de S, ¿no?
Yes, and to describe the appearance, right? How they look like. Great.
Yes, I think.
Yes, thank you, Brisa. That would be it. Okay, so there's a lot of information we can get from each one of these systems. And I think that would be it for today's class, guys. It took us a lot of time. Tomorrow, we're going to have a little bit of theoretical class, just like today. And right after, we're going to have our practice class, okay? Did you understand today's topic? I mean, it was interesting, right? Okay, so we're going to have our daily survey, okay? Okay, here it goes.
I'm done.
Okay, thank you. Thank you so much. Okay, I think we're done with our survey. And okay, guys, I'll see you tomorrow, okay? We're going to have practice class tomorrow and a little bit of theoretical class. So have a good night's sleep, and you have homework for tomorrow. You're going to tell me about la escala de Kurb, okay? And some other questions I'm going to remember what are going to be your homework for tomorrow, okay? Have a good night's sleep, and I'll see you tomorrow. See you guys.
Bye.